What is going on, guys? This is Dr. Ryan Garner with Apothicor Wellness. Today we're talking about why I'm less concerned about what PBMs are doing and more concerned about what they're not. So let's get after it. We all know PBMs, pharmacy benefit managers. They're essentially your pharmacy insurance, right, in healthcare. And they've kind of become this necessary evil, right? On one hand, they're doing a lot of great things for their clients. They have a network of pharmacies. They negotiate prices with these pharmacies, they negotiate rebates with manufacturers, and they're establishing formularies for their clients. Now, that's not to say that all their practices are so great, because some of them have been under quite a bit of scrutiny. The first one that comes to mind is something like spread pricing, where they pay the pharmacy one amount, turn around to their client, tell them a different dollar figure, and they're pocketing the difference. To me, PBMs kind of feel like a kid getting caught with their hand in the cookie jar, right? Almost like they know what they're doing is wrong for the reason that they're so quick to pivot to the next thing. So as soon as spread pricing became a lot more aware, now PBMs are trying to retain more of their clients' rebates from manufacturers. And I guarantee you, even in today's market, most clients don't know how much they should be getting back from manufacturers from rebates. So it still is a relatively opaque process, but nonetheless, there was awareness as to PBMs holding on to some of these rebates, and they again pivot to the next thing. Right now, it tends to be utilizing GPOs or group purchasing organizations, and these are PBM owned. Sometimes they're also owned by other companies. But these guys are the ones that are negotiating manufacturer administration fees on behalf of the PBM. Now, essentially, this is a commission to the PBM for sales on a drug that they've placed on formulary. The difference is because the GPO is owned by the PBM but not the PBM themselves, the PBM's clients really have no claim to those fees. And while I'm not saying that these are good things, good practices, as I preface the video, I'm way less concerned with this stuff than I am with the things that we think that they're doing, right? I very frequently talk with brokers, and when I talk with them about what Apothicor Wellness does and where we are as far as the process, we are upstream of PBMs. We work with the providers to assist clinical decision making, making sure that patients are getting the best outcome using the lowest cost drugs possible. The rebuttal that I'm often met with is, I think we're good. We have a transparent PBM. They do prior authorizations. They have step therapies. It sounds like, we have everything all covered. So in the world of healthcare, we're really under the belief that prior authorizations and step therapy is what is, reducing costs as much as possible, as if they are actively trying to reduce costs, and that's just really not the case. But before we can understand how step therapy and prior authorizations are actually not what they seem to be, we first have to look at how PBMs are making the bulk of their profit. There was a report released in September of 2023 by Nephron Research that did actually outline how PBMs in the market are making the bulk of their profit. The majority of the way that they are making their profit starts with specialty drugs and the fees or spread that they're collecting on these drugs. And now if you're in healthcare, you know very well that specialty drugs are incredibly expensive. They can range on the low end from $1,000 a month to something like Humira in that $6,000 a month range, and certainly go far beyond that dollar figure. Now, even if they're keeping a small percentage spread on an expensive medication, it still ends up being quite a bit of money that their clients are having to pay on top of the cost of the drug. So we can see that PBMs really have no reason for their clients' members not to be using high-cost specialty medications. The second way in which they're making a bulk of their profit is from mail-order pharmacies. Now, they've kind of got a cheating edge here because not only are they filling the medication, but they're also negotiating the reimbursement for the drug in the first place. Regardless, if we assume that they're making similar margins to that of most retail pharmacies in this country, we can assume that the margins are fairly low on every prescription. Right now, retail pharmacies have to push large volumes just to remain profitable because the margins are so tight. Not to mention, Higher cost medications typically have a higher margin when it comes to the reimbursement, not as a percentage, but as a total dollar figure. The third way in which PBMs are making their profit is fees paid to the GPO groups, these administration fees that we talked about that are essentially a commission that get paid to the PBM. Now, typically, rebates and administration fees are not paid for generic drugs. It can happen, but it's really not super common. For the most part, administration fees and rebates are paid on brand name proprietary drugs that tend to be a lot more expensive, right? They're getting paid to put that product on formulary that's going to generate more sales. So because this is a higher cost brand name drug, the PBM is making money when their clients' members are filling that. Again, we can see that the PBM has zero reason to want the discontinuation of high cost meds because they are actively profiting from it. So we can see ultimately that PBMs are making money on specialty drugs that are very expensive. So again, no reason to want to discontinue those. On mail order pharmacy, which profits when there's high volumes and high cost drugs, no reason to want to stop that. And lastly, on fees paid through GPOs, and those are only on brand name drugs, high cost drugs, and again, no reason to want to stop that. So now that we've looked at how PBMs are making their profit, we can look at things like step therapy and prior authorization and see how they really don't align the way that we think they are. First one that we're going to look at is step therapy. Now, step therapy is exactly what it sounds like. There are steps that must be taken before we can get to the next level or the next drug that gets prescribed. Step therapy tends to be very guideline driven, okay? Now we'll take, for example, something like the diabetes guidelines. So the ADA, the American Diabetes Association, their guidelines essentially allow almost anything to be prescribed first. So what a step therapy might look like is before we can have somebody on something like Ozempic, the PBM will want to see that they've taken any other medication for type 2 diabetes. The problem with this is that it can be very easy to manipulate. We can claim that a patient is intolerant to something, had a side effect. If a patient has a minor side effect and doesn't want to take it, the PBM will give them the green light to the much more expensive drug because they have essentially completed that first step. The PBM will either want to see that they failed the original therapy because side effects or lab values were abnormal, or they'll want to see the patient is still continually taking that medication, but they're not quite at goal. But what we have to understand is that step therapy is not clinical decision making. It is not actively trying to decrease costs for their clients. It is just fulfilling one step, and then we can move to the next one. So the next thing we're going to talk about is prior authorization. And prior authorization is essentially a checklist, if you will, okay? It is really making sure that the patient that is being prescribed a drug, and yes, these are usually tied to higher cost drugs, but what it is a checklist to make sure that the patient's characteristics meet the inclusion criteria of how the drug was studied. For example, a drug like Repatha will have prior authorization that makes sure that the patient's characteristics meet the inclusion criteria of the 4-year trial, which was the study that essentially showed Repatha's efficacy. This would be something like patient needs to be ages 40 to 85, have a history of cardiovascular disease, have an LDL above 70, and be on a maximally tolerated statin. Now what this does is it almost kind of assures us that the patient being prescribed this medication should receive the exact same outcome as the patients in the study because their characteristics meet the inclusion criteria. But prior authorization is not some kind of clinical practice where the PBM is looking at ways to retroactively decrease these costs. They're not looking at ways that we can decrease LDL from a lifestyle perspective, trying to figure out why the patient isn't on a maximally tolerated statin, what issues there are, what other drugs could have been tried. So we have to understand that PBMs are this very stagnant barrier to preventing, drugs being used unnecessarily, but it's not actively trying to decrease costs. And the last thing we're going to look at is PBM's clinical services. These really are PBMs following up with patients who have high-cost disease states or are on relatively expensive drugs. And these services are essentially following up with patients, making sure they're taking medications as prescribed, just to ensure that they are getting the most out of these medications that they're using. So ultimately, when we look at things, we can see that the services that PBMs offer really aren't doing as much as the healthcare world believes. They're not clinically trying to decrease drug utilization. In fact, we've seen based off their profits, they have no reason to. Doing things like step therapy and prioritization really fulfills the minimum of obligation to their clients to try to decrease costs. But we can see that they are making money when their clients' members are filling high-cost drugs. Thanks for watching, guys. Check us out on LinkedIn, and don't be afraid to subscribe to our channel.